Hello, colleagues. I'm Professor Subodh Verma from the University of Toronto. I'm a cardiac surgeon and professor of surgery and pharmacology. I also hold the Canada Research Chair in Cardiovascular Surgery. I'm really delighted to share with you one of our late-breaking presentations at the EASD 2025 meeting entitled Semaglutide and Risk Reduction of Major Adverse Limb Events in Diabetes, a pooled analysis of 13,975 participants from the SOUL, FLOW, and STRIDE randomized trials. And I present this to you on behalf of my co-authors that are listed on this slide. These are my disclosures. Now, as many of you know, peripheral arterial disease is a global problem. It's a recalcitrant problem with limited solutions. Over 200 million people worldwide are affected by PAD, and the prevalence is rising. It's often underdiagnosed and undertreated, especially in elderly people and people living with diabetes. It carries very high morbidity in terms of claudications, ulcers, gangrene, and amputations. It is also a cause of major functional decline and reduced quality of life. Peripheral arterial disease is associated with high rates of major adverse cardiovascular events and cardiovascular death. And we know that functional impairment in people with PAD leads to frailty, leads to social isolation, and also is an important cause of depression in patients. PAD is underrepresented in clinical trials and receives limited funding. And for the last 25 years, there have been no available therapies to improve walking capacity in people living with PAD. Now, the statistics from different regions in the world, shown here as an example from Ontario, Canada, where I live, suggest that lower extremity amputations related to diabetes and peripheral arterial disease are actually on the rise over the last decade. So these data, as we've echoed in the paper, really support the renewed efforts to prevent and decrease the rates of limb loss in people living with diabetes. Now, there have been 3 trials of GLP-1 receptor agonists in people with diabetes. The SOUL trial that looked at oral semaglutide in people with type 2 diabetes who had atherosclerotic cardiovascular disease and or CKD. The FLOW trial that evaluated people living with diabetes and CKD. And more recently, the STRIDE trial, where we evaluated people with diabetes and symptomatic peripheral arterial disease. And you can see the sample size of the 3 trials: 9,650 patients in SOUL, 3,500 patients in FLOW, and just short of 800 patients in STRIDE. And these trials really all met their a priori primary endpoint, which in the SOUL trial was a 14% reduction in major adverse cardiovascular events. In FLOW, a 24% reduction in major kidney events with semaglutide versus placebo. And in the STRIDE trial, which was a functional outcome study, we demonstrated that maximum walking distance was improved with semaglutide compared to placebo. Now, male outcome or major adverse limb events were key secondary endpoints in SOUL and were supportive secondary or additional secondary endpoints in the FLOW and STRIDE trials, respectively. Now, there were some insights that GLP-1 receptor agonism with semaglutide may actually have benefits on limb events or major adverse limb events in the FLOW trial as well as in the STRIDE trial. And as you can see here on the left, the FLOW trial, the SOUL trial, the point estimate for major adverse limb events is really consistent with what appears to be a benefit to reduce the limb events in people living with diabetes, regardless of whether they have atherosclerotic cardiovascular disease or chronic kidney disease, with point estimates of 0.71 and 0.56 respectively. And on the right-hand side, you see people living with diabetes and prevalent PAD. And here we found that a sort of exploratory endpoint, which was defined as really a endpoint to evaluate progression of peripheral arterial disease, which was a composite of rescue therapy initiation or all-cause death or major adverse limb events, was also reduced favorably with semaglutide. The numbers were small here, but the point estimate of 0.46 seemed to be consistent with what we were seeing in the broader populations of people with diabetes or diabetes and ASCVD and diabetes and CKD. So we really thought it was important to carefully evaluate and adjudicate major adverse limb events across the pooled cohorts. And I just want to remind you that major adverse limb events really were adjudicated by an independent committee according to pre-specified criteria for hospitalizations for acute or chronic limb ischemia. And the outcomes included time to the first adjudicated confirmed major adverse limb event or acute limb ischemia or chronic limb ischemia hospitalization, the composite of male or all-cause death, male or CV death, male or major adverse cardiovascular events. Now, when we look at the pooled cohort of patients from SOUL, FLOW, and STRIDE trials, you can see here that we're just short of 14,000 participants in this pooled analyses. Mean age is 67, 70% are male, baseline A1C 7.7%, baseline BMI was 30 kilograms per meter square, quite prevalent hypertension, coronary disease as expected. LDL cholesterol was relatively well treated at baseline, 2.0 millimoles per liter. Half of them had a history of coronary revascularization. About 6% had a history of lower extremity revasc. The vast majority were treated with ACE inhibitors, ARBs, lipid-lowering therapies, and antiplatelet therapy and anticoagulant therapy were used in 60 and 10% of people, respectively. So a really large sample size of people living with diabetes across the spectrum of ASCVD, CKD, or prevalent PAD. And as you can see here, the sort of primary endpoint of our analyses was adjudicated confirmed major adverse limb events in this pooled analyses from SOUL, FLOW, and STRIDE. And this yielded a hazard ratio of 0.70, consistent with a 30% relative risk reduction with respect to confirmed major adverse limb events with semaglutide versus placebo, a p-value of 0.0072, and really quite a dramatic improvement in major adverse limb events, I think noted for the first time across a sort of pooled cohort of people with or without PAD who actually have diabetes and risk factors. Now, what about time to first adjudicated ALI, acute limb ischemia or chronic limb ischemia hospitalizations? And you see on the left, the ALI hospitalization hazard ratio, again favoring semaglutide with a hazard ratio of 0.77, and the chronic limb ischemia hospitalization hazard ratio also favoring semaglutide with a hazard ratio of 0.72. We also looked at time to first adjudicated and confirmed male according to the prevalence of PAD at baseline. And as you can see here, really there was a benefit seen in people with and without PAD. The P interaction was not significant, suggesting that really semaglutide had efficacy to reduce major adverse limb events, regardless of the prevalence of PAD at baseline. And I think this is a really important observation that semaglutide seems to not only reduce, male events in people with prevalent PAD, but may also be effective in reducing sort of the first manifestations, so-called incident PAD events in people with diabetes without prevalent PAD at baseline. Now, finally, if you look at all of the other endpoints adjudicated in the pooled analyses, as I mentioned to you earlier, male was reduced by 30%, the composite of male or all-cause death by 15%, male or CV death by 18%, or male or MACE by 17%. So really consistency in terms of the limb events and the limb and cardiovascular and mortality events combined in favor of semaglutide versus placebo. So really to wrap it up, these are quite important and really exciting data for people living with diabetes, who have PAD or are at risk of PAD-related complications. We demonstrate in this pooled analysis of approximately 14,000 individuals that semaglutide versus placebo is associated with a 30% reduction in major adverse limb events, a 28% reduction in chronic limb ischemia hospitalizations, reductions that favor the composite of limb events and cardiovascular death, or limb events and cardiovascular, major adverse cardiovascular events, or CV death. And therefore, when we think about this sort of holistically, this really now ushers in a completely novel and previously unrecognized role of semaglutide in a population for which we have very limited solutions, and that is people with PAD. But thank you very much for your attention, and I hope you enjoyed this presentation.